comparing the effects of blood pressure control in patients undergoing non-cardiac surgery, whether it's hypotension or hypertension avoidance strategy. More than 300 million patients undergo non-cardiac surgery annually, and many of them are on chronic antihypertensives which are continued perioperatively. Hemodynamic instabilities are frequent in these hypertensive patients intraoperative and postoperatively, and this is known to be linked to major vascular complications. With the current knowledge, there is no good understanding of what is the best or optimal blood pressure management strategy in non-cardiac surgery patients. Some of us would withhold ACE inhibitors and ARBs to reduce the vasoplegic effects intraoperatively, while for beta blockers, some studies have shown it's best to continue it perioperatively. Generally, we keep intraoperative MAP 60 and above, and it is not known if keeping it higher, which is 80 and above, would improve outcome. This was the research question. In patients undergoing non-cardiac surgery who are at risk of vascular events, what are the effects of perioperative hypotension avoidance strategy versus hypertension avoidance strategy on the 30-day incidence of major vascular complications? For the study design, 10,000 patients to be enrolled in a transendemic acid or placebo trial in a partial 2x2 factorial design, expected to have 6,500 patients in the blood pressure trial. The patients, healthcare providers, and study personnel were not blinded to the blood pressure treatment assignment, but the outcome assessors were blinded to the treatment assignment. The inclusions criteria were patients at least 45 years old, undergoing inpatient non-cardiac surgery, had risk factors for perioperative cardiovascular events such as hypertension, stroke, ischemic heart disease, chronic kidney disease, and chronically taking at least one antihypertensive medication. For those who had poor functional status of NYHA class 3 or 4, or with an ejection fraction of 30% or less, were excluded. These patients were randomized to one of the two blood pressure management strategies. We define hypotension avoidance and hypertension avoidance based on the blood pressure abnormality that the strategy preferentially intended to avoid. For hypotension avoidance strategy, patients' medications were managed based on a specific algorithm pre-operatively and post-operatively. Their ACE inhibitors and ARBs will be held pre-operatively and the first 2 days post-operatively, while other chronic antihypertensive medications were given based on an algorithm. Intraoperatively, particular attention were given to maintain patients' MAP of at least 80. This is the algorithm for hypotension avoidance strategy for other antihypertensive medications apart from ACE inhibitors and ARBs. For the hypertension avoidance strategy, all of the antihypertensive were served as usual, inclusive of the ACE inhibitors and ARBs. And the MAP of at least 60 and above were maintained intraoperatively. So the primary outcome that we are interested in is major vascular complication, defined as composite of vascular death and non-fatal myocardial injury after non-cardiac surgery, stroke, and cardiac arrest at 30 days after randomization. We randomized close to 7,500 patients across 110 centers in 22 countries. And these were hypertensive patients chronically on at least one antihypertensive medication undergoing inpatient non-cardiac surgery. 99.9% of them completed the 30-day follow-up. There is no difference between the two groups in terms of baseline characteristics, such as age, gender, number of chronic antihypertensives, percentage of patients on ACE inhibitor or ARBs and beta blockers. There is no difference in primary outcome between the two groups. Around 14% in each group experienced major vascular complications with a p-value of 0.92, which is not significant. There is no difference in secondary outcomes, namely myocardial injury after non-cardiac surgery, myocardial injury, stroke, vascular mortality, and all-cause mortality. None of the p-values showed statistical significance. With respect to the tertiary outcomes, which comprises of non-fatal cardiac arrest, hemorrhagic and non-hemorrhagic stroke, acute congestive heart failure, new clinically important AF, and sepsis, there is also no difference between the two groups. We found that compliance with the planning strategy was not optimal, but it is expected in a complex intervention. Fortunately, the degree of compliance actually did not play a major role because we did not find a difference between the two strategies in centers with a greater compliance. We also looked at the effects of the two strategies on hemodynamics. We did not find major differences in systolic blood pressure and heart rate between the two groups as well. So in conclusion, POISE-free blood pressure trial is answering our research question, showing that there is no difference in terms of major vascular outcomes between the perioperative hypotension avoidance and hypertension avoidance strategy. Even though you can regard this as a negative outcome, but POISE-free blood pressure trial is important because it informs two crucial questions that confronts anesthetists every day. Now you know there is no difference whether you target an MAP of 60 or 80. There is no difference if you continue all the antihypertensive or withholding ACE inhibitors or ARBs in hypertensive patients who are chronically on antihypertensive undergoing non-cardiac surgery. Further research is needed to identify and evaluate perioperative intervention that might have an impact on hemodynamics to the extent that will eventually lead on a favorable impact on clinical outcomes. I hereby end my presentation and would like to thank you for your time and attention.